Does that work? Can you hear me? Okay, awesome. Well, you brave souls, thank you for sticking around. I want to use the time that we have to share thinking that my colleague from the Urban Institute, Tim Waidmann, and I have been doing on the data and research gaps that seem to be hindering policy development and forward progress with respect to health sector investments aimed at reducing unmet needs for a range of different non-medical health-related social issues. We started by assessing the role that Medicaid and Medicaid managed care plans are playing in helping enrollees address their non-medical health-related social needs, and trying to identify the driving forces behind the activities that are and investments that are occurring. In addition, we tried to absorb the information that's publicly available on this topic, and we conducted key informant interviews with Medicaid officials, managed care plan reps, academics, national policy experts, and other key stakeholders from around the country. And I think this day is indicative. We found a veritable explosion of innovation and activity, and many exciting examples have been shared today. But we also found consensus that rigorous evidence is sorely lacking to guide investments in policy development. And I'm just going to highlight a few of the themes that emerged. Carolyn, in her great presentation, identified a number of unresolved issues and pressing research needs with respect to the specifics, the who, the what, the how of screening for social needs, and the impacts of plan and provider screening for those needs. But in addition to those important issues, there's really a need for systematic assessment of the extent and nature of unmet health-related social needs at a population level for different subgroups in Medicaid and Medicare and writ large, nationally at the state level and at lower geographies. It's that analysis that really gives us the grounding on where the major holes are in our safety net and where investments in other safety net programs may be particularly needed. Housing has come up several times today, and there's a statistic that seems really grounded empirically that just 1 in 5 people who meet the eligibility criteria for housing subsidies can actually get them, given the constraints on the public resources that are available in that area. So that raises fundamental questions about how much payers and plans can actually do to help people address these housing needs and other unmet social needs if we don't address those funding constraints. But combining profiles of the unmet needs for these different in these different areas together with information on the resources that are available to address those needs feels like a fundamental first step in helping identify gaps that could also galvanize investments, policy changes, and I think picking up on what Dr. Lindau and Dr. Chakshi said, perhaps potentially galvanize the political will to address kind of problems in those other sectors. So as you've heard from Kelly, there's a clear need to address how unmet social needs individually and in combination affect health. But as if that's not challenging enough, we also really need to understand the negative impacts unmet social needs that influence health have on non-health sectors and how investments that affect health play out over time. Several people have mentioned this. As the Admiral indicated at the top of the meeting, we really need to reckon with disconnects between who's bearing the costs of interventions and who's reaping the benefits. The infamous wrong pocket problem rears its ugly head, I think, really consistently in this arena. And we really need to be focused on understanding so Dr. Miller's models can be really solid and convincing and robust, how addressing specific unmet health-related social needs actually affects different outcomes that matter and spending across sectors. We need to identify that at different levels of government, given the way budgeting processes work, and over different time horizons. We all know that decisions by policymakers at federal, state, and local levels are driven by budgetary considerations, as well as by a host of considerations in terms of outcomes. But current budgeting timeframes are quite narrow, quite often limited to a single year. And so understanding medium and longer term implications is going to be critical if we're going to incentivize investments that have significant payoffs over the life cycle. Our current approach also undervalues investments that produce positive impacts and savings across multiple sectors and across different levels of government. As we saw in Ross Owen's presentation earlier today on Hennepin County, some states and localities are investing heavily in administrative data systems that bring together information from different sectors like Medicaid, Child Protective Services, criminal justice, income supports, education, housing assistance. These systems provide information about overlap, the extent to which the same individuals are touched by more than one program, and potentially by more than one caseworker. But they also can be used to support assessments of how interventions in one sector affect costs and outcomes in other sectors. I would say this is an area where we really need more investment on the research side, both on the implementation, how these systems get launched, how they're maintained, and it'll be really critical to share successes across the country and to transfer knowledge and experiences with respect to design, implementation, and maintenance of these systems. I think that's the only way, or I think it's going to be a critical path toward taking a more cross-sectoral approach to investments. I want to highlight a couple of additional areas where the evidence base seems especially lacking and where there's a greater need to understand trade-offs. Specifically around with payers and designating specific services that can be covered versus reimbursed by plans versus letting plans decide how to use a flexible pot of money to meet needs that they observe. A second question that we think looms large is how targeted do investments need to be to create a sustainable, convincing business case for payers and plans? And in particular, if substantial healthcare sector investments in addressing social needs require a strong business case along those lines, does that mean we're going to be consistently deprioritizing investments that yield benefits and savings to other sectors or that take time to materialize? And I'm looking at you children. I think in particular that's a real risk that this focus will deprioritize investments in kids. And then finally, to the extent that health payers and plans do focus on helping their enrollees meet particular social needs that are pressing, is there a risk that other population groups will see their access to those services decline? And could it undermine the ability of payers and plans to meet the medical needs of their enrollees? So just questions to put in the mix in terms of the dynamics. So I think I'm out of time, and so I'm going to pass the baton back to Seth.